So if they didn't do any prep and you take the scout and you see a bunch of feces in the colon, the radiologist may not want to proceed with the exam. So preparation could be one. Perforation, if they're looking for that as a possibility, that would play a role more so in the type of contrast media that we would use. We wouldn't give the patient barium if we were trying to rule out a leak, or if we were trying to rule out a perforation. So what do you think we should give the patient instead for those?
The gaffer, yeah,
mm-hmm. The gastrographin, right. What did you guys see some of those in your textbook? The contrast media?
And I believe it was in, you talked about it last semester in 1010 when
mm-hmm.
we, in our 1010 chapter of contrast.
Yes, and it should be in your, there should be a little bit in your big book too,
okay.
The bond tracker. Mm-hmm. All right. So once we do that, we're going to obtain the history because we want to make sure that we give the radiologist that information as well as far as the patient's history, so that way they can make their, know what they're looking for during the actual exam. So what we're going to do today is go through those overheads for the esophagram, the upper GI. Small bowel is really simple because there's just a bunch of KUBs, so that's nothing really important there. As far as any major positioning changes, and then the last one is the overheads for the BE. Okay. Once you obtain that information, the patient's change, you talk to the radiologist. You're then going to also do the scout film that you were starting to mention, Takosha. What does the scout film do? Why do we do that?
To compare after, like before and after.
So not so much before and after.
For the contraindications of the patient to see if the barrier animal or the gaffer should be used.
Mm-hmm. So that's one reason, and also just to see, we could see if there's fecal material that'll be in the way, and we could also see the main reason why we do that is if the patient, a lot of times when the patient has the GI problems, they've had other testing done. So they may have residual contrast from another exam that's remaining in there that will hinder the new exam that was ordered.
Okay.
So if it's an inpatient, you may have to wait like a day to do the new exam because you don't want the old contrast being in there, and then you're trying to figure out, okay, which one's the old one, which one's the new one. So that's usually the main reason why we do that. All right?
Okay.
All right. Miss Wallace, you gonna be the patient again today?
Yeah, I couldn't put the sheets on there. My bed was already used.
Oh man, that's like a first.
We don't have all of our sheets. That was just me.
Yeah, because usually we're able to go like 2 days, like 2 classes, and well, I guess we could just wipe down the table in between.
You want me to take the sheet off?
No, you're it's fine. We were trying to wash the other sheets really quick, but
I just left it down there so I can put it in.
Okay. All right. Nadia, I'm gonna borrow, this is yours, right? I'm gonna borrow yours because I couldn't find mine and I didn't want to waste time looking for it. Over here? Okay. All right, so with the esophagram's a little bit different with the scout because for the esophagram, where is that region that we're looking at? Yeah, it's up high, right? It's the esophagus. So with that one, instead of doing a scout, which is pretty much an abdomen KUB, we're gonna go higher. Okay, we're gonna almost do like a chest X-ray so we can see high up. And then usually what we do is we just kind of cone in. We don't open it all the way to see the lung field. We're just trying to make sure there's nothing obscuring that esophageal region. So that's usually what we do for the esophagus. Or sometimes they don't even really do a scout for the esophagus. So it just depends on where you are. But the routine overheads for the esophagus, typically we're going to start off with the patient in a standing up position. erect if they're able to tolerate that. Not all of your patients are gonna be able to tolerate that, so it's gonna be patient driven. So usually we start them off standing up, and then when they're standing up, they're going to be with their, back against the board. So they'll be supine facing you. The radiologist will usually ask them to drink some contrast material. So with that contrast, we're gonna have it in a cup. Sometimes we typically will have a straw in the cup, and it's a thicker straw because the contrast material. There are different consistencies of it, but even if you use the thinnest consistency, it's a bit thick to go up a regular straw, so they usually have thicker straws. And then normally what happens is we don't wanna have, typically when you're drinking something, you have your cup right here, right? So we don't wanna have their cup right here because you've got a whole cup of barium or contrast media right in front of the area of interest. So we'll have them drink to the side, or sometimes we'll have them take a sip and hold the contrast media in their mouth and then move the cup away, and then we'll tell them to swallow so we can actually see it going down. So when they're standing up, we usually do AP image, and then we will have them turn to the side to do a lateral image as well. Once that's done, we're gonna lay them down, and then the first thing we're gonna do is a RAO. So you'll see two positions in your little pocketbook, the RAO and the lateral, and then you have the AP laying down as well. So typically, once we lay them down, what we'll do is we'll actually, because remember this table is, the floral tables can go all the way fully erect. It has a footboard at the end that the patient's gonna stand on. So normally, once the radiologist comes in and he does his images of the AP and the lateral, we'll have the patient turn and face the board, so that way when we lay the table down, they're kinda already almost in an RAO. And once it gets flat, like how Miss Wallace is, we'll then tell them to go ahead and lay on their right side for the RAO. So that's usually the easiest way of doing it. So with the RAO, well, first I'll just start off with the AP since we saw the AP. So when you're doing overheads, depending on where you are, you can either do overheads with the fluoro and take images that way, or they may use the CR, okay? So either one works fine, so you just gotta follow what they do at your various sites. So if we're working with the esophagram, how do you think your receptor should be positioned?
Portrait.
Portrait, right? Because we always want to go with the length of the body part that we're utilizing, all right? So I'm just going to switch this around to put a portrait. And then make sure that's lined up, which it is. All right. So the centering point for the esophagus is very similar to that of the chest x-ray. We're going to go to the level of about T6, or you can do 2 to 3 inches below the jugular notch. So you can use the jugular notch as a reference point and go a bit below that, and you should be more or less in the same region. Miss Wallace, scoot towards me a little bit. So I'm just making sure she's centered on the table. Again, we already have the patient's change. Everything is removed. You want to make sure for the esophagams, you definitely have no jewelry, necklaces in the region as well, okay? All right, so I'm going to just bring your shirt down so we can see your jugular notch. So Miss Wallace jugular notch is about here, so we're going to go a little bit lower than where her jugular notch is, okay? Remember, we're going 3 to 4 inches below that. So about there. All right, so we're centered, we're midline to the patient, we're at the level we want to be. Last thing is this collimation, right? We're going to we want to leave it open long ways, but we can definitely close it in side to side because the esophagus is very narrow. All right, so when we have the patient lay down to take our still image, this is one of the ones you're going to do. It's just the AP. So what was one of the other ones I mentioned?
RAO.
RAO.
So you would still do another AP even if you did it standing already?
It depends. So normally, the radiologist is always gonna come in at the beginning for any of these fluor exams, with the exception of the small bowel. And they're gonna come in, take images that they wanna take while the patient's drinking the contrast media, and then usually they leave. Sometimes they take everything that they wanna see, and sometimes they don't. And they'll say, okay, go ahead, you can finish. So if they tell you to finish, or they tell you to go ahead and take overheads or do your spot films, this is what we're doing. So it just depends. For the most part, with everything being digital now, usually the radiologist will just take everything because it's just kind of convenient and it makes sense to. But sometimes if they're busy or they just don't want to be bothered, because the radiologists typically don't like to do fluoro exams. So it just really just depends. Have you encountered one that likes to do fluoro exams? Because I usually don't on my end. I was like, can't you just do it? What do you need me for? All right, so that's your AP. So then we're gonna do a lateral, and typically we do a left lateral. And we always like to do a lateral. When you're doing that, make sure that you have the patient turned towards you. So most of the fluoroscopy units, just like the x-ray rooms, are gonna have a little window just like we have here. And we want the patient to turn towards us, because if anything's going on with the patient, we wanna be able to see that. Okay, if their back is towards us, we can't really see if they're having a reaction or if they're starting to vomit or things like that, okay? So I'm gonna have Miss Wallace turn towards me. So she's actually gonna be in a right lateral. I think I said left before, I'm sorry. Let me bring this forward.
Just take it off.
Okay. And normally, once you have your center on the patient, you typically don't really have to make that much adjustments because you're just moving the patient. So I'm just having her turn on her side, so she really shouldn't be that off from where my initial central rate was, okay? All right, so Miss Wallace is nice and lateral. She's got her arms already up out of the way for me, which is what we want. Her knees are also bent, and that's gonna give the patient a little bit more stability, all right? So when we're doing the lateral, same thing. If we might need the patient to drink some more contrast, we can hold the cup for the patient, have them drink, or just give them some, have them hold it in their mouth, and when we're ready to make the exposure, we tell them to swallow it, and then we can capture the contrast media, fill in the esophagus as it goes down. All right? So I'm gonna go up a little bit more, or bring the swallows down. Yes, just this much. Thank you. All right. And then we're still aiming for the same region like we would for chest x-ray, but we're not gonna go midline to the patient because we wanna get the esophagus, that's interior.
Okay.
I'm gonna actually have her bring her arm down behind her because I wanna make sure it's not in the way of the esophagus, okay? So by right here, we're good. So she was to drink. I can clearly see I'm in the correct area that I need to be for the esophagus. Again, you just want to make sure you're closing in your collimation from side to side. And then you're gonna, and then you're gonna, so now I'm probably about the level of the jugular notch because I want to make sure I'm able to see it going from her mouth region down into her esophagus and then as it goes into the stomach.
Okay.
So sometimes when you're doing this, the esophagus is a little bit in length. So usually what the radiologist will do as well as the patient's drinking, he may actually move the x-ray, the tower, as it goes down to capture it entering into the stomach region. And they can do that from the controls in the room.
Okay.
So they'll like kind of follow it as it goes down. Also with the esophagram, they like to do what's known as rapid sequence or rapid fire. And basically that just increases the amount of images that are captured when you make an exposure. So instead of you making your exposure and you just have one image, it'll take like 4, 6, or 8 images back to back to back, like super fast.
Is that a function that you would set like on the computer?
Yeah, so usually if they want something like that, they'll do it themselves, or usually we typically know, especially with the esophagram, because it goes so quick, we just automatically hit that option for them, and we just let them know, oh, it's already on rapid fire or rapid sequencing.
At the VA, when they were doing it, they did it themselves. Just like moving outside.
They kept like making the exposure?
No, they said that it was on rapid,
Okay.
and they just used it now because he did it himself.
Oh, okay. Okay. Okay, so you got to see
Yeah.
something. Okay. All right, so this is your lateral. So what do we have next?
RAO.
So RAO, so now my patient's gonna lay facing the table, and they're gonna be a little bit onto their right side, right? Because RAO is right anterior oblique. So we want them facing the table, but not completely prone. We want them up on their right side, a little bit. You're going LAO.
It's like your spot quiz.
Oh, so that maybe she was trying to trick you guys. All right, so we've got the patient up on their right side. Same thing, we're still gonna be in the same vicinity, so I really shouldn't have to move the x-ray tube up and down too much. I'm just gonna make sure I'm here more anterior to where the esophagus is gonna be.
Okay.
And as you can see, we've got other structures overlying, so we've got our shoulder region in there, we're gonna have ribs and lung field. That's okay because the contrast material is gonna enhance the esophagus, so it's really gonna pop, like we saw on some of those images. So it's gonna show up, usually they have it to where you'll see the contrast media appearing white on your studies, but sometimes they do invert it and flip it. I don't know if you guys remember Mr. Cunningham talking about that with the C-arm and the things were opposite. Sometimes they'll do that, but usually they have it to where the contrast media appears white. So any questions so far?
Yeah.
All right. So I'm going to keep Miss Wallace there since she's an RAO, so we don't have to torture her. And we could go into the positions for the upper GI. So what area is the upper GI focusing on?
The stomach.
So it's primarily the stomach. And typically when you start the upper GI, you're going to have the patient, sometimes they have the patient start off in a standing position as well. But sometimes if your patient's not able to stand, you may have to just do everything with them laying down. All right, so just, it's a little bit patient driven. But the upper GI, we always do a RAO, and usually we do the RAO a little bit towards the end because this is the position that we like to put our patients in, that it's going to fill the duodenum region of the small bowel, and we can see that duodenal bulb is what they call it, really enhanced and nice, okay, which is the very first part of the small bowel region. So your textbook says to center at the level of L1 or 1 to 2 inches above the lower ribs and midway between the spine and the upper abdominal border. So that's a lot. All right, so when they talk about the lateral border, so when we're RAO, what side, to begin, what side do you think your stomach is going to be on? So point on Miss Wallace, where do you think the stomach would be?
Like in this region.
Yeah, so you don't want to be over here because the stomach's on the left, right? So we're going to go over to further down towards her left side. And when they talk about the border, you can feel the ribs on the patient. So that's one of the reference point that they're mentioning. So you want to go halfway between the lateral border of the ribs and the spine. Okay? So the spine's here, the lateral border's here, so halfway between those two spots. So I'm going to scooch over a little bit. And then it also makes reference to, where is it? So that's halfway. Okay, no, that's good. And then the oblique is going to be about 45 degrees. Okay? So Miss Wallace is pretty much there. The collimation, you can close it in because now we're just focusing on the stomach. So I'm going to close it into about there. All right, because we don't need to have it as large as we did for the esophagus because the stomach isn't as long, but it is a little wider. So we want to make sure that we capture all of the stomach. And then you might make some minor adjustments depending on your patient body habitus. In your book, I think, yeah, your book is going to tell you the minor adjustments you may need to make based on your patient's body habitus. All right? Because remember, our asthenic patient, the stomach's going to be really, really low. Our hypersthenic patient's going to be up and high and across. So you may need to make some minor adjustments based on your patient body habitus.
Would you be able to like put like a pillow, like say for someone that can't really hold themselves up, it wouldn't affect, it wouldn't be.
Yeah, so you could put a pillow or you could put like the 45-degree sponge there to give them some more support. So that would be your RAO stomach.
What are the breathing instructions for these moves?
Expiration.
Yeah. So normally we'll just tell the patient to let all their air out, hold their breath, but you definitely want to tell them to, don't take the image while they're breathing because then you're going to have motion on your images. So that's your RAO. So questions with that one? All right, so Ms. Wallace, can you go into a left lateral for me? So how is Ms. Wallace going to be if she's going into a left lateral?
Left side down.
Left side down, he's slightly back.
Mm-hmm. Okay. Do you want me to put the sponge? We could put the No, but I was saying I could put that there.
Sponge.
Gonna make it hard, make it difficult when you see it.
Well, we'll
Have a thin one, baby.
You know what? Just do the right lateral because their book says right lateral anyway. Yeah.
Because that's what we did.
Mhm. Yeah.
Our patients complain about the table being hard.
It's like a mat.
Yeah, very thin.
All right. So we got her in the right lateral. So now we're gonna come up a bit. So you want to come up to where the stomach is, and you don't want to go again too midline. You want to come a little bit anterior because the stomach, when you are relating it from the anterior posterior, it's a little bit anterior. So we don't want to. We want to make sure we get it in our film. So I'm going to come a little anterior, and that will be your right lateral.
And this for the stomach.
So this is for the stomach. This is for the upper GI exam.
Okay.
So again, the radiologist is going to come in initially, and they're going to take a bunch of pictures while the patient is drinking the various contrast media. And then what they'll do is once they leave, they either might have taken everything they need, or they may tell you to go ahead and do your spot films or go ahead and do your overhead films. So that's what we're going through now. Yep. So that is your right lateral, because every time you move the patient, you're going to see the changes in the contrast media and in the air. So when you're looking through your little book, you'll see how, okay, in this position, I'm seeing ear in the fundus, I'm seeing contrast media in the body, or the pylorus, and then it'll switch depending on the patient, changing the various positions. So that's why I was saying you guys really want to pay attention to that, and they have it, the little color chart somewhere back here, I saw it, just like they have in your textbook.
So do you need to start like PA or AP? Like, do you need to start with a specific one so that the contrast media doesn't kind of like move to, because I assume it can't go back, so.
No, it will. Like when you move your patient, it's going to move as well. But typically, for the upper GI, they usually will start that with the patient standing up as well. And they'll start it with the patient facing supine. So they'll be AP. That's how they'll start it. And then usually they'll go LPO, they'll oblique the patient, and then they'll lay the table down. And before they actually start getting into these positions we're doing with Ms. Wallace, they'll usually have the patient do a log roll. So they'll roll on the table 2 times, like a log, to help coat the stomach, and then they start doing their additional use. But they're not gonna have an 85-year-old do a long roll, so that's not happening. So it just kind of depends on your patient and their mobility. Another thing they do with the upper GI, I didn't mention it in lecture, but sometimes they'll give the patient what's called easy gas, which is these little crystals. It's like a little packet, and it's like Alka-Seltzer almost. They put it in a little medicine cup and they add water to it, or they'll just call it fizzies because it fizzes when you add the water. They'll have the patient drink that, and it puts air into their stomach, so it expands the stomach so the radiologist can see it better. But you need to tell the patient it's gonna make them want to burp. So you gotta tell the patient not to burp, to try to hold it in, so that way they can keep that air expanded in their stomach.
And that would be before the contrast media is introduced?
Mm-hmm. Yeah.
Okay.
All right, and then the last one we'll do is the AP. So Ms. Wallace, you can lay back on your back. So for your AP, the central ray, it's saying to be at the level, so now we're going a little bit further down from the jugular notch, 5 to 6 centimeters below the jugular notch. So we're going a little bit further. And you don't have to be exact on, you don't have to do like bust out, a ruler or anything like that. You could kind of, if you know your anatomy, you should be able to determine where the region of interest is. So we know the stomach is going to be a little bit off to the left, so I'm going to go a little bit more to the left, and then I'm going to come down just a tad. All right? So we're coming below the jugular notch again. It's going to say 6 to 8 inches below, and then you're going to go off a little bit toward the left because that's where your stomach is positioned. So this would be your AP. And again, we've never changed the collimation, so once you have your collimation fixed, you don't really need to change it because you're still looking at the same area, right? So PA, you have PA in here, but we really don't do a PA. Usually we just do AP because that's kind of uncomfortable for the patient to be in PA. So we just do the AP, the RAO, and the right lateral. And I'm going to show you guys one more. You guys got LPO in here. So with your LPO, you're going to have the patient oblique 45, but towards the left side. So I'll just tell my patient turn a little bit towards your left. And then you might have to move the table over a little bit just to make sure you're not missing the stuff with them. So that would be my LTO. So any questions? You're okay. All right. So I think I'm gonna hold off on doing the barium enema and combine that with the positions for the IVP. Because the IVP is just pretty much abdomen KUB and obliques. The barium enema has a little bit more positions, and I don't want to jam pack too much in here because I think the barium enema you could probably do up to 6 positions. So we'll save that for next time. But the other thing I wanted to talk about was the small bowel, because that's pretty simple. The small bowel is the one that usually takes about an hour. That's the one that's timed every 15 minutes. You're going to come in and do a KUB on the patient. All right? So the patient doesn't even necessarily have to be in a fluoroscopy room for this. Sometimes we just have them in a regular room. And basically they're going to be laying flat supine. And you're centering, where's our centering point for the abdomen? So we're gonna be, so we could use the iliac crest, so we're gonna center right at the level of the iliac
Iliac
crest,
crest.
and we wanna be midline. I'm not even seeing the small bowel in here.
Page 302.
Oh, okay.
I went too far.
So small bowel, we're just doing a series of KUBs. For the small bowel, we will again do that scout image first. And we're going to, once we have it cleared with the radiologist, we'll give the patient, the contrast media to start drinking. Normally, we just give them 2 full cups of contrast media. Whether it's barium if we're using or gastrographin, we give them 2 full cups. We typically will have them drink that first cup, take an image, and then we have them drink the second cup, and then we'll take another image, and then we'll start the 15-minute sequencing after that. When we do our initial films, we typically go a little bit higher above the iliac crest because we want to make sure we get some of that stomach in there. So we'll go 2 inches above the iliac crest for the first one, like the first 2 images. And then after that point, we'll start leveling at the iliac crest. Now, when you do get your third film, if you're at the iliac crest and nothing is moved out of the stomach and everything's still centered in the stomach, okay, so you know you want to make an adjustment and still go a little high. Because everybody moves differently. So some people might still have a bunch of contrast in there, and some people, you know, they might be on the way to the, you know, through the small bowel. So look at your patient and pay attention to how the contrast media is moving throughout their system. So the iliac crest, remember that's really high up on the side. You let your patient know you're feeling for the iliac crest. So I'm gonna come down, and I'm not changing my receptor because it's still portrait, which is where I want. So if we're doing the first one, I just went up 2 inches above my iliac crest because I wanna make sure, again, I get that stomach in there. Once I get my first 2 images in, I'm gonna start centering at the level of the iliac crest. All right. So with these, every 15 minutes, we're taking a KUB, an image supine with the patient. What did I tell you guys to do in between the films while you're waiting that 15 minutes? How should your patient be?
Lying still.
Well, they're gonna be laying still, but I want them on a specific side.
Yes. Right?
So you're gonna turn them onto their right side, and that's gonna help the contrast to move out.
So
and
during the
continue.
15 minutes, put them on their right side.
Yeah. Yeah, that too. That'll help too. If your patient can walk, you can have them walk around, have them sit in a chair. That'll help the contrast move along. All right. And then when it's time for your 15 minutes, you come back and do your another KUB. So you're gonna keep doing that same process every 15 minutes. You're doing KUBs up until an hour. Now, when you're doing these images, you want to make sure you're sharing it with the radiologist. You send it to PACS, let the radiologist know, hey, I just did my 30-minute film. I just did my 45-minute film. You're annotating on there what film is there. So that way the radiologist, you know, sometimes if everything is just kind of like at a standstill, they may say, all right, do one in 30 minutes as opposed to 15 minutes. Or you might have that rare patient that it moves super, super fast. And they may be hitting the TI spot in 30 minutes, and the radiologist will have to come and do their little spot cone film. So you want to make sure you're communicating with the radiologist as the procedure goes through. So usually when you get to your 60-minute film, which is your hour film, that's usually about the time frame that the contrast material will start to enter into that TI region that we talked about, which is the terminal ileum. So that's the very beginning part of the large bowel. And that is the indication, okay, it's all the way through the small bowel, so now you need to do your spot films in that area. So that's where we were talking about the compression cone. Sometimes the machine will have a little, looks like a little triangle cone that you could slide in here, and you can maneuver it down to press on that right lower quadrant region to help spread out the bowel so you can see that TI spot enhanced better without the overlying bowel loops. If you don't have the compression cone, you should have a manual paddle, I have to look for it, it's somewhere. You have a manual paddle that has like the circular, shape, and it has the little bulb at the end that you can, inflate the balloon, and you can manually come in and press on the patient with that to help spread the bowel out.
It's like a paddle.
Mm-hmm.
It looked like a tennis racket.
Yeah.
Mhm.
Yeah, there's a picture of it in your textbook. It's in here, it's somewhere, I'll find it and show it to you guys. But you can do that too, but just make sure you communicate with your patient, that you're doing that so they're aware, you know, cause, you know, you don't know if they have surgery, if they're having pain in that area, so you wanna make sure that you're aware of that. Also with the manual option, the automatic cone that comes down, you can control it coming down and going up, but there is force to it, so you wanna be mindful of that. You don't wanna like squeeze the patient, and you wanna be careful in your positioning because your iliac crest, your ASAS is right here, okay, in that region of where you need to be, so you don't want that sharp pointy cone coming right on their ASAS, it's gonna hurt. So just be kinda cautious and mindful of that as well. But for that spot film, usually the radiologist will come in and do the spot films. Sometimes if they're busy, they might tell you, well, you go try to do it, you do it. So you could try to do it. Sometimes we might have to oblique the patient in an RPO to kind of help open it up. Sometimes if you oblique them LPO, it helps open it up. Everybody's a little different. So you can try it too, but you can definitely cone in the collimation. You don't have to have it opened all the way like we do here. You would cone it in probably about to here, and then we would just come over to the right lower quadrant region, because that's where your TI region would be.
Okay.
So that's where we would be. Typically, when you're using gastrografin for the small bowel, usually they don't typically do a spot film, because with gastrografin being water-based, by the time it gets to that point, it starts to like almost fade, for lack of better words. It's not as prominent, so you really can't see it as in detail. So usually with that option, they don't bother doing the spot. And then you have your obstructed patients that this exam can take like 10 hours, 15 hours. So it's really important that you document on there the timing and when the radiologist says to do a next film. Sometimes they might tell you if it's not going anywhere, do another film in 2 hours. So usually for those patients, or usually inpatients, that occurs too, and we usually just send the patient back to their room and we just do a portable abdomen instead of having the patient come back and forth.
Are they allowed to go to the bathroom?
Yeah, they can. But they can't have anything to eat or drink until the exam's over. Yeah, all of these exams, they're for the upper GI and usually for the small bowel, they're MPO midnight before, and they can't have anything to eat or drink until the exams are over. The esophagus, they don't really push it that much. And then the barium enema, that's the one where they usually will have like a whole 2-day practice, although most of the time they don't do it. So,